blood pressure monitoring and the danger of acute hypertension. Number 1344, September 1, 2025. Gerald C. EclaireMD Foundation. Category: Hypertension and Stroke. Introduction. Blood pressure, BP, is a dynamic and sensitive biomarker that reflects both long-term vascular health and short-term physiological and psychological responses. Traditional medical research and clinical practice, grounded in statistical methods, emphasize averages such as resting systolic blood pressure, SBP, and diastolic blood pressure, DBP, taken once or twice daily, except in the intensive care unit, ICU, or emergency department. However, stroke and other vascular events are often precipitated by acute surges, rather than by long-term averages alone. My own medical history illustrates this point. On June 21, 2025, a sudden rise in SBP to 175 mmHg triggered a hemorrhagic stroke in the pons area near my brainstem. This event did not emerge from chronically elevated averages, but from one violent surge that overwhelmed an aged and stiffened cerebral vessel. Following this life-changing incident, I committed myself to an intensive self-monitoring program. Free from the demands of office work in my retirement years, I applied engineering, mathematics, physics, and pathophysiological perspectives to systematically analyze my self-collected big data. My primary purpose is personal protection, but I also aim to highlight the limitations of relying solely on statistical averages in hypertension management. This paper presents my 2-month intensive blood pressure dataset. Approximately 3,600 readings, calculated as 20 times 3 data points per set times 60 days, analyzed through both quantitative methods and pathophysiological reasoning. It further outlines my plan for a year-long program of extended monitoring and reflects on how such self-collected, longitudinal data may deepen understanding of the dangers associated with acute hypertension and stroke risk. Methods. Over the past 2 months, I measured my blood pressure 24 to 30 times daily, approximately once every 40 minutes during waking hours, using validated digital BP devices manufactured by Omron. I did not record nighttime values since I was not in a hospital setting. Alongside BP, I tracked heart rate to monitor for bradycardia, a condition I experienced most recently on August 30, 2025. For each measurement, I recorded systolic blood pressure, SBP, diastolic blood pressure, DBP, heart rate, HR, contextual notes, physical activity, emotional state, hydration, food intake, and medication timing. This dataset represents approximately 1,800 sets of readings per month, or 3,600 readings across 2 months. I also maintain a parallel database of dietary intake, now exceeding 2,000 detailed records, which I expect to expand to more than 60,000 entries within 1 year. BP, HR, and other lifestyle factors combined. Results. Averages. SBP, 115 mm of mercury. DBP, 70 mm of mercury. PP, pulse pressure is SBP minus DBP, 45 mm of mercury. Wake-up readings. SBP, 112 mm of mercury. DBP, 67 mm of mercury. PP, 45 mm of mercury. Peaks. KO highest SBP, 149 and 143 mm of mercury. Highest DBP, 128 mm of mercury. The average pulse pressure of 45 mm of mercury is lower than my recent baseline of 50 mm of mercury, from 2024 to 2025. This initially appears favorable but still indicates vascular stiffness due to aging, since pulse pressure does not fully normalize despite lower averages. Notable spikes. 2 significant hypertensive episodes were recorded, with systolic blood pressure, readings of 143 mm of mercury and 149 mm of mercury. Upon review of contextual notes, both episodes were linked to emotional stress. During legal discussions about my last will, an inherently unpleasant and stressful subject, this has shown that wealth does not necessarily bring positive influences to ordinary human life. Having enough is sufficient, while excessive wealth often brings nothing but trouble. Analysis. At first glance, my BP profile over this period appears normal. My average data fall within ideal ranges, suggesting good overall control. However, deeper analysis shows that averages can obscure real health risks associated with extremes, outliers, or noisy data. My 2 hypertensive spikes, though brief, demonstrate my system's susceptibility to acute surges. For most individuals, a temporary 149 mm of mercury might not cause concern. For me, however, such a spike is a reminder that another 175 mm of mercury surge is possible, as already proven by my June 2025 stroke. From an engineering perspective, blood vessels can be viewed as aging materials with reduced elasticity. In younger individuals, arteries buffer pressure fluctuations, much like a shock absorber or a new flexible water pipe. With aging, vascular stiffness diminishes this capacity. As a result, any sudden stress, emotional or physical, transmits unfiltered force directly to fragile cerebral microvessels. In my case, hemorrhagic stroke risk is disproportionately tied to the amplitude and rate of rise of blood pressure spikes, rather than to the average load alone. Pulse pressure further reinforces this model. My average PP of 45 mmHg during the past 2 months is lower than before, but still remains elevated compared to the ideal range, 40 mmHg or below. This suggests that stiffness persists and continues to limit the arterial system's resilience. Discussion. The central lesson of my dataset is that acute hypertension, not average hypertension, is my true enemy. Clinical guidelines often emphasize long-term control of SBP is smaller than 120, and DBP is smaller than 80, which I already maintain. Yet such targets do not fully protect me against hemorrhagic stroke. If acute surges occur, 2 hypertensive events in the past 2 months may appear minor. But in a high-risk patient with vascular stiffness at age 78, they represent potential stroke precursors. Importantly, both episodes were linked not to physical exertion or dietary mistakes, but to emotional triggers. This highlights the psychophysiological chain of events, where psychological stress translates into sympathetic nervous system activation, vasoconstriction, and a sharp rise in SBP that can culminate in stroke. My plan for 1 year of continued monitoring aims to expand the dataset to around 30,000 BP and HR readings, plus detailed lifestyle records of diet, activity, and sleep. This will allow me to build a high-resolution map of my cardiovascular responses, identifying which triggers are most dangerous. For every SBP above 130 or 140 mmHg, I will log a probable cause. This persistent, detailed analysis should allow me to distinguish random fluctuations from reproducible patterns. By combining food intake and walking exercise data with blood pressure spikes, I expect to clarify the interplay between diet, exercise, hydration, and especially emotional stress in shaping my vascular response. In this way, I hope to separate myself from the statistical summary that suggests 40% of stroke patients will suffer additional strokes. From a research standpoint, I also raise the question, how many single patient datasets of this depth exist in medical literature? To my knowledge, very few. Most hypertension studies are population-based, relying on averages and cross-sectional data. My case study represents a different research approach, longitudinal, individualized, and intensely granular. While not generalizable to all patients, it may illuminate mechanisms of acute hypertension that averages obscure. Conclusion. My 2-month intensive monitoring highlights a paradox. My average BP profile appears excellent, yet my stroke risk remains high because of acute surges. Vascular stiffness from aging means I no longer have the buffering capacity to withstand spikes. 2 hypertensive events above 140 mmHg were clearly linked to emotional stress, underscoring the role of psychology in hypertension management. Over the next year, I plan to collect more than 30,000 blood pressure and heart rate readings using 2 devices. Omron wrist and upper arm monitors, together with records of food, exercise, and sleep. I will also include continuous heart rate tracking to help prevent bradycardia or vasovagal events. This combined dataset will give me unprecedented clarity about my own hypertension and bradycardia. It also raises broader questions about the limitations of population-based averages in medical research and the potential role of extreme longitudinal self-tracking in uncovering patterns of disease risk, particularly for heart attacks and strokes. Ultimately, my lesson is clear: averages do not protect me, but vigilance over spikes might. This is more than data collection, it is a matter of survival for me and for others. Disclaimer: this content is for educational reference only and not medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be edited or republished as your own. Appendix: rarity of my case in existing literature. In preparing this paper, I also asked an AI system to search the existing medical literature to determine whether other cases like mine exist. My goal was to learn whether other individuals have undertaken such intensive, longitudinal, single-patient blood pressure monitoring, combined with contextual notes, dietary tracking, and heart rate measurements. The AI search found a few partial parallels but no direct equivalence. Some published studies have used N-of-1 hypertension trials, where patients self-monitored BP to personalize medication regimens. These studies demonstrated the value of individualized data, but generally lasted only a few weeks, and produced far fewer measurements than I am collecting. Welton et al. 2018. Similarly, the widely used method of 24-hour ambulatory blood pressure monitoring, ABPM, typically records values every 15-30 minutes during the day and 30-60 minutes at night, for 1 to 3 days. In some cases, these ABPM assessments are repeated at intervals over months, but they do not extend to continuous year-long monitoring. Strand-Gaird and Paulson 1994. Standard home BP guidelines also recommend only 2 readings per day, morning and evening, for 1 week when evaluating hypertension control. Franklin 2004. These conventional approaches emphasize efficiency and feasibility across populations, but fall far short of the 24 to 30 daily readings I take for months and years at a time. Finally, the broader personal science and quantified self-literature documents individuals tracking BP and other biomarkers, but none approach the data density and contextual depth I am producing. The reason I take this approach is to capture isolated and sudden episodes of acute hypertension, which are often triggered by a combination of personality traits, such as advanced pattern recognition, and a short temper, and psychological or emotional stressors. Based on this review, I conclude that my project, to collect more than 30,000 BP and HR measurements in 1 year, paired with dietary, exercise, sleep, and stress monitoring records, is likely unprecedented in published medical literature. This dataset will not only allow me to understand my own risk of acute hypertension and stroke in extraordinary detail, but may also stand as one of the most comprehensive single-patient cardiovascular case studies available to science. References as below: 1, 2, 3, 4.